A very warm welcome to my masterclass, A Stepwise Approach to Airway Management. Being a paramedic operationally, we use the stepwise approach very often with patients who need the best airway management to suit their needs. So today I'm going to show you a scenario involving an unconscious patient and the management that I will give this patient using the stepwise approach. So the first thing I'm always going to do with any unconscious patient is assess their response using the AVPU scale. So firstly I'm going to elicit a response using my voice. If that doesn't work, I'm then going to use a pain response by squeezing the trapezius muscles. If that doesn't work, I can then class this patient as U on the AVPU scale. And for the purposes of this scenario, he is U on the AVPU scale. Just to confirm also that for the purposes of this scenario and simulation, I will not be using any live oxygen cylinders due to it being flammable, and we cannot use those in the training centre environment. Okay, but obviously operationally, dealing with real life patients, we would use our oxygen. Okay, so I've tried to elicit response. He's now U on the AVPU scale. I need to sort out his airway because it's very noisy. So the first thing I'm going to do is I'm always, before I touch the patient, I'm going to check and visually inspect the airway. So I'm looking with my pen torch, okay? I'm trying to have a look to see if there's anything causing the snoring and causing the noise and causing the blocked or occluded airway. When I visualize with my pen torch, I can't actually see anything. Now, this is not a trauma patient. There's been no trauma involved, so I can do my manual head tilt chin lift maneuver. However, if there was trauma involved, I would simply do a jaw thrust to sort my airway out, okay? But because there's no trauma involved with this patient, I'm going to do my head tilt chin lift. So I've already looked in my airway. I'm happy there's nothing in there. So I'm just going to do a head tilt chin lift, and then I'm going to recheck my airway, visualizing it as I go. So there's no change with that airway. I can't see anything in the airway, and I'm happy to move on. My patient is still snoring. He's still not getting enough oxygen. So what I'm going to do is, while I sort out my adjuncts, I'm going to place him on 15 litres of oxygen via a non-rebreather mask, and it's going to be inflated, attached to my oxygen cylinder at 15 litres, okay? So whilst I'm doing that, I'm going to be sizing up my first step on the stepwise approach, which is the oropharyngeal airway. So we've done our manual manoeuvres, and we could always have done as well some simple postural drainage to see if that had worked. But for the first approach, we're going to use our OPA. So I'm just going to show you, I've got 3 different sizes here, okay? 3 different sizes of the oropharyngeal airways. Now, to size them up, what we do is we go from the mandible in the line of the airway, okay? We go from the mandible to the incisors. So as you can see, that one's a little bit too big, so we're not going to use that one. I'm going to try this little green one here, and that's slightly too small. So the next thing I'm going to do is I'm going to try the orange one. From the mandible to the incisors, and that one's perfect. So before I insert this, I'm just going to remove the oxygen. I'm going to recheck with my pen torch, making sure there's nothing changed in there. I'm also going to have my suction ready, always, with my Yanka catheter. And I'm going to insert my OPA. I'm going to invert it along the hard palate, reaching the soft palate, inverting and turning it the right way. And then I'm going to place my oxygen back onto my patient, 15 litres with the bag inflated, okay, and making sure it's nice and tight around the face. Now, he's still snoring, unfortunately, so that's our first step of the stepwise approach. We need to up it to the next step because the airway is still noisy. So what can we do? Well, what we're going to do next is we're going to use one of these, which is a nasopharyngeal airway, or an NPA for short, and they come in sizes 6 or 7. I'm going to use a 6. So to measure it, I'm going to go from the nares to the tragus, again in the line how I'm going to insert it into the airway. So once I'm happy, I'm going to remove the 100% oxygen again. I'm going to go for the right nostril, as that tends to be the biggest in most adult patients. I'm going to insert it with a beveled end facing the septum, and I'm going to go in an anterior to posterior motion with a slight twist of it. Nice and gentle, we don't want to cause any trauma to that highly vascularized nasal area. Once I've done that, I'm going to place my patient back on 15 litres and see if that's worked. And for a while, this has stopped the noise and the snoring of the airway. So the patient is breathing for themselves. I've got good rise and fall of the chest. His saturation levels are good, but there's still no response. And now, unfortunately, this patient now goes into respiratory arrest. So the first thing I'm going to do is remove the oxygen mask. I'm going to attach my BVM, my bag valve mask, to the oxygen, 100%, 15 litres. This bag will be inflated, okay, in real life, and I'm going to place it on my patient using the C and E grip, pulling the jaw into the mask, and I'm going to ventilate a third of the bag, one every 6 seconds. And I'm getting really good rise and fall here, both equal. There's no tension on my bag, and my oxygen saturations are good. So what I would continue to do now is I would get my colleague to continue to ventilate one every 6 seconds, a third of the bag, whilst I think about upgrading to the next step of my approach. Because this patient's in respiratory arrest now, so I need to upgrade my airway. So I'll ask my colleague to continue to ventilate whilst I size up my eye gel. So with eye gels, which are supraglottic airways, these are my eye gels. So I've got 3 different types here, okay? I've got a 3, a 4, and a 5, okay? What I'm going to do is I'm going to use the 3, I think, for this patient. Now, how you size them up is you look on the front there, and you note that there's a size of weight. So it's 30 to 60 kilos on this one. So this is the one I'm going to use. Now, to prepare the eye gel, there's a little notch here on the cradle. I'm going to pop some lubricant in there, and I'm going to lubricate the back and the sides, okay? And that's ready for me to use now. What I need to do as well is, before I insert my eye gel, I'm going to get my laryngoscope ready, okay? So this is going to visualize the airway a little bit further, just to ensure there's nothing in the airway. So when I'm happy, I'm going to tell my colleague to stop ventilating. I'm going to remove the OPA with suction ready, and I'm going to visualize my airway. I'm happy there's nothing in the airway still. I'm going to insert my eye gel following the hard palate all the way to the bite block, and then I'm going to quickly place my BVM on the eye gel and just again ventilate one every 6. Okay, what I will do is I'll ask my crewmate just to hold the bag and take over ventilations whilst I place my stethoscope on. But in simulation, I'm going to just take it off a sec while I put my steth on. Place this back on. Okay, and I'm going to check to see if I have air entry. So I've got good air entry, good air entry, good air entry, good air entry. So I'm happy that my eye gel is in place. I've got no tension on my bag. My capnography reading, which I'm going to attain in a moment, will help me know that it is in the right place. But at the moment, my saturation reading is sufficient, okay? So what I will do is, again, I will ask my colleague to take over ventilations whilst I tie and secure the eye gel into place. So we'll pretend that my colleague is now ventilating for me, and I'm going to tie off the eye gel. So there's a few ways to tie off, but the way I'm going to use is, I'll show you now. So we want it nice and secure. We don't want this eye gel, we don't want this eye gel moving once we've got it tied off. So he's getting nice ventilations, one every 6 seconds by my colleague at the moment. So for purposes of the simulation, I'm just going to use a bow. However, if this was a real patient, I wouldn't want it moving at all, and I would cut it if I was going to take it off. But for this purpose, I'm just going to use a bow, but I would normally knot it. Okay, so again, my crewmate will have been ventilating for me. So again, I'm just going to get them to squeeze the bag whilst I listen and just reconfirm that I've got good air entry. Which I do. I'm happy that I've got good air entry. What I'm going to do now is I'm going to attach my airway circuit. Firstly, my catheter mount, then my filter, and then my all-important capnography. So that will go into my corporals machine and will assess, excuse me, how much CO2 this patient is giving out. So I would like it between 4 and 6, and any sort of spike will indicate that actually he started breathing for himself. And as I'm monitoring him, I'm checking for equal rise and fall of the chest, misting in the eye gel, and obviously checking for any tension on the bag, monitoring my SATs and end tidal. So I'm happy with that, and my patient is being monitored throughout. All of a sudden, he now starts to show improvements and signs that he is starting to breathe for himself. So I'm feeling some resistance on the bag when I ventilate. I'm seeing some moans and groans, and I'm seeing some flickering with the eyes. So the first thing I'm going to do is remove this. I'm going to have my crewmate with suction ready. I'm going to be talking and reassuring my patient at all times what's going on. Remove the eye gel tape. And then on the peak of inspirations, I'm going to ask my patient to take a nice deep breath in, 1, 2, 3. I'm going to remove the eye gel, and I'm going to have my suction ready if needed. So suctioning rules are only suction what I can see, suctioning on the way out, not on the way in, suction in a figure of 8 movement, and only suction for 10 seconds at a time. So once that's achieved, and I'm happy that there's nothing in the airway still, he's not snoring anymore, he's come round, I'm going to just place him back on the 15 litres of oxygen with a nice inflated bag, just to monitor him into the hospital. Obviously, the beauty of the stepwise approach is, as well as being able to go up the stepwise approach, I can come down the stepwise approach at any time. So I hope you enjoyed my masterclass, and be safe out there.